So I want to talk to you a little bit about broken hearts. How many people have had a broken heart? Raise your hands. Is there anybody who has a broken heart?
Husbands, yeah.
Really? How do you get through life without?
Girlfriends.
Oh, you had two broken hearts. Her heart has been broken twice, not just one. Oh, you've actually, I mean, just felt like you broke your heart. That's what I was talking about. I know that I have felt like I've broken my heart. I mean, it starts when you fall in love with that first kid in second grade, or I don't know when, high school I think it was for me. Then my husband, who I'm currently married to and dated for 4 years before we got married, he broke my heart at least 3 times. He doesn't anymore though. So I think that heartbreaks can be painful for anyone, and especially for the person on the receiving end, speaking from experience. I think everyone's probably suffered a broken heart at some time in their life, whether it was a pet, a loved one, somebody who didn't reciprocate on love. And so I went through, I did this Google search on how many songs I could find that actually had broken heart in the title. And there are a few. The first one that came to mind was Al Green's How Can You Mend a Broken Heart? We all know that one. I'm not going to sing any more of those. No Broken Hearts by B.B. Rexa. Best songs come from broken hearts. Any country singer would say that. Nashville Cast. Where Does a Broken Heart Go? Jim Reeves. Where do broken hearts go? Whitney Houston. Broken Heartsville, Joe Nichols. Don't Break My Heart, UB40. Somewhere in My Broken Heart, Billy Dean. But the best one is Achy Breaky Heart. And so because we don't have the aspiring acapellas here with us tonight,
That's from Melody. It's good. Cyrus. Yeah. I took the kids just for a day. Oh my God.
you want to get up and dance? Okay, everybody's going to sing the chorus. Ready?
Tell my fingertips, they won't be reaching out for you no more. Don't tell my heart, my achy, breaky heart. Just don't think you understand. And you tell my heart, my achy,
You can line dance too if you want to. I don't know how to line dance. I don't have cowboy boots on. Oh, I can't do that here.
Singers that usually come and sing and make funny.
you can tell your doctor about the way.
Oh, you want to hear the whole thing?
No, it's not this time, right?
Are you kidding me?
Usually have more things
I don't see anybody dancing though.
very carefully.
You know the words by now.
He's loving it. The only guy in the room. Get a lot of money. No, it's not. Again.
All right, don't tell the aspiring acapellas that I gave them this competition.
I know, I read about that.
And so, now that we had that opening, I'm going to present to you our next guest, Dr. Bob Martin. He's spoken to you before. He is our cardiologist in the Wisconsin Rapids, Stevens Point area. I don't know if you remember much about him, so let me tell you about Dr. Martin. He is a graduate of the University of Arizona Tucson Medical School. He did his internship at the Oakland Naval Hospital in internal medicine and his residency at the Oakland Naval Hospital, also internal medicine, and then his fellowship at the Naval Medical Center in San Diego for cardiology. Dr. Martin joined the Navy because he wanted to serve those who serve us. He loves Star Wars movies and The Christmas Story. You know, the one where he gets his tongue stuck. I always thought that was kind of sad, but the lamp, though, is funny in that. The Fragile lamp. I think he has one of those in his office, as a matter of fact. He and his lovely wife, Cindy, and Cindy is here this evening. There she is, over in the middle. Have 3 adult children and a flat-coated retriever named Willow, who likes to chase cars and motorcycles. But otherwise, it's a delightful dog. She got to stay with me for a week. And I would like to show you a little video about Dr. Martin. Oh, he said.
Started out wanting to be an architect. When I decided that wasn't in my future, took a year off from school, talked to an advisor in the biology department at the University of Arizona who suggested going into a major called medical technology. After that, I ended up talking to somebody who suggested if I wanted to do medical research, that I should become a physician. My emphasis became more in dealing with patients instead of dealing with research. Entered the Navy after medical school. Did my medical training basically entirely in the Navy. The reason for going to the Navy was to serve the people who serve us. My and my wife's decision to come to Wisconsin Rapids and work for Aspirus, and we interviewed and visited the community, saw the community, met some of the people, and it just seemed like a good place to come to. To me, a great day at work is seeing a patient that I've seen before that was a success. We've got that collaborative relationship where they're taking ownership of their medical care, and I'm basically just helping foster them through that. Prevention is actually my interest, especially exercise in relation to prevention. That's a big part of what we do to help prevent cardiac disease. I know diet's part of it as well. I think it's really important to actually listen to what patients have to say. Patients, like anybody else, want to be treated like people. They have a story to tell. I think it's my job to hear that story.
I love that video of Dr. Martin. I think that really truly captures the essence of who he is. He's a good man and a good doctor, and we are so fortunate to have him here in Wisconsin Rapids with us. So without further ado, I present you Dr. Bob Martin.
looking at that picture and then looking at this video and the video that we saw before, I think next time I'm going to come with one of them mullets. That seems to be very popular, I guess. Let me see if this is going to work. Oh, I guess I'm supposed to have the broken heart thing on there.
Oh, that was first.
There we go. All right, that's what I'm here to talk about. That's me. I just wanted to use this slide to thank Dr. Murdoch up in Wausau, because he's the one that put most of these slides together. I'm kind of stealing them from him. But I just want to give credit where credit's due. He's the author of most of these slides. And you'll see it as we go on, because the patient that is discussed in here, actually a couple of patients are not my patients, but they're kind of representative. And so that's why we use them as something to talk about. All right. So I'm here to talk about what's often called broken heart syndrome. This is, these are the other names it goes by. We usually call it Takotsubo, and I'll talk about that a little bit, in a little bit, where that name comes from. It's also called stress cardiomyopathy or apical ballooning syndrome, and I'll show you pictures of why it is we call it that as well. All right, so if we're going to start with a patient story. So this Jane Doe walking her dog on a summer day. This is in 1989. Again, this is before I got here, so that's how you know it's not my story. So once she was in the woods, she let her dog roam freely around. And unfortunately, ran into a bear trap. So the dog was killed. And Jane Doe then developed abrupt onset of chest pain, neck pain, became short of breath and worsening short of breath over time. And then she made her way back to her car and drove herself to the hospital. Now, I realize this is out of necessity, but I would like to counsel folks, if you can find somebody else to take you to the hospital, it's probably better. But this was necessity, so you know what they say about necessity, so that's what this one was. So this was up north, so she went to the Eagle River emergency room there, where she had a blood pressure of 88/60, which is on the low side. I know some people that run that normally, Cindy Martin. But the pulse was 110, and that's a little fast. So she's heart rate's fast, blood pressure a little low. It's not usually what you want to see. Lung exam showed rales and wheezes. Rales are basically, it's a sound that the lungs make when fluid's filling up in them. Her heart rate again was fast. She had an S3 gallop. Again, an S3 gallop is a sound that the heart makes when it's failing. Okay? So that's what she had on exam. Now this is an EKG and a X-ray, and this doesn't, I wish we'd have done the slides a little differently and actually kind of use these as each one as an individual slide, but the bottom line is, and you can't see it all that well, I mean, the X-ray you can see pretty well. So there's a heart, there's the lungs are kind of darker, and then there's some blood vessels and stuff you can see in there. And then here you see you kind of lose all that border. You can't see the heart very well. It's kind of a big bunch of fluff. And that's fluid, okay? Fluid that's built up in the heart, or in the lungs, I'm sorry, because the heart isn't working correctly, and we'll talk about why it's not, what happens to it in a minute. EKG, this is a normal EKG, and again, this is what doesn't project very well, but there's, the bottom line is that this looks like a heart attack, all right? You can see, if you see here, there's like these spots right here are very elevated compared to the baseline, and if you look over here, they're not. And that's the thing on the EKG, it looks like a heart attack, all right? So this is her EKG and her chest X-ray. This is a normal one, and this looks like a heart attack, all right? And the other things, like I said, the S3 and the RALs and all that stuff kind of goes along with that as well. So what was the diagnosis that she was given? Well, an extensive anterior wall myocardial infarction, that means heart attack. Complicated by congestive heart failure, so that's the fluid backing up into the lungs. And then she was in cardiogenic shock, that's basically the blood pressure's low and the heart rate's fast, okay? So that's what she got diagnosed with. She presented and was given TPA, that's a clot buster, okay, and that's what we often use to treat people that have what we think are having heart attacks at the ER there in Eagle River. Then she was immediately put in an ambulance and rushed off to Aspirus Wausau Hospital for further evaluation and treatment. When she got to the ER there, she was met by a cardiologist and taken directly to the catheterization laboratory. And had an urgent cardiac catheterization. So cardiac catheterization is something we do to urgently look for blocked arteries, and then if we can, try to open them back up again. So again, it's looking like a heart attack. We're treating it like a heart attack at this point. So what they expected to find in one of these anterior myocardial infarctions is this is an oops, I get my buttons right. This is the artery, that's the artery going down there, and it shows basically a clot that's blocked off an artery here. And when you squirt dye down there, you get a cutoff. It just doesn't flow down there because there's something blocking it, okay? Because normally there should be something coming down here. So that's what they expected to find, because that would have fit the EKG and the rest of the story. But this is what they actually found. That's that same artery right there. It wasn't blocked, all right? And neither was any of the other arteries. The rest of them all look good too, okay? So the blood supply looked normal, and there's no significant blockages here. So in addition, another part of the test for heart catheterization is what's called a left ventriculogram, where they actually look at the squeezing chamber of the heart, and they evaluate how well is it squeezing, because that's what its job is. It squeezes and pushes blood around. So on that, this is a normal one on the top, where this is roughly the size, and then as it squeezes down, everything kind of squeezes down in unison, and everything kind of squeezes down the same. What you see here is Jane Doe's, and this is what's commonly seen in Takotsubo, or broken heart, is it's, number one, it looks a little bit big and kind of oblong-y shaped compared to that to start out with. But then when it squeezes down here, okay? But that doesn't squeeze very well until it kind of balloons out. That's why it's also called apical ballooning syndrome, and that's the ballooning. That's the apex here, or the tip of the heart here, and so that's what balloons out. So that's what they actually saw for the heart function, and then we saw before what they saw for the artery. So it looked odd, because this is obviously not normal, okay? But we would have thought it would have been a heart attack, and then the arteries looked all fine. So it was like, well, what's going on with all of that? And that's basically where we're going now. Something strange has happened, and so now the time to try to figure out, where is this coming from? So additional evaluations, again, she had this presumed, then they thought that maybe she had a presumed dissolved clot in her artery. In other words, the clot formed and then her body broke it down and then it opened everything back up again. So they started, that's what they thought, and then they searched for a clotting disorder to see if there was, she had a tendency to clot. And then they did an echocardiogram, which is a different test to look at heart function, to look for a cardiac shunt to see if there was a place where blood was going where it shouldn't go, and they didn't find that either. So basically they came up empty. They didn't really find an answer as to what happened to her. So what was the rest of the story as far as Jane Doe is concerned? Well, her heart failure and blood pressure rapidly improved. So basically it was kind of a temporary thing. Came and went fairly quickly. She was discharged 2 days after she was admitted with no signs of any cardiac problems at all. She was sent home on a medicine called beta blockers, and I'll kind of allude to them a little bit further on down the road here. And then she had another one of these echocardiograms, which is, again, this is kind of one of what they kind of look like, although it moves. 3 weeks later, and it showed a normal heart. So her heart went from looking really ugly and not functioning very well to completely normal. And we didn't do anything. I mean, we put her on a beta blocker, but other than that, there's no arteries to open, there was nothing going on. So she just kind of got bad and got better on her own, more or less. So this is a summary of the case. So she's a postmenopausal female, which I'll talk about that a little bit too, presented with symptoms of and clinical signs of a heart attack. So again, it looked like a heart attack after she had an emotional stress with her dog dying. No artery blockage was found. Evaluation for the cause of a transient blockage of the artery in the flow they didn't find anything. And then she completely recovered. This is talking about the 1990s, because that was 89, and that's when this all kind of Takotsubo / broken heart syndrome kind of came to light. Nobody really known about it before. So over the subsequent decade, this is again we meaning Aspirus, identified more similar cases that were associated with stress. Almost always were female. And again, extensive evaluation didn't show anything as to why it was that this was happening. Now, in 1990, that's this paper that was published in Japan, that's Japanese, for those who don't know, by a Dr. Hiroku Sato, who called it Takotsubo syndrome, and basically that's essentially exactly what we were seeing. And he described several cases where he saw similar kind of presentations. This is where Takotsubo, the name, comes from. These are these pots / they're really traps that they catch in Japan. They catch octopus with. All right, and it's called Takotsubo is the name of the pot. And so if you look at it, it looks kind of like, again, it's tight down here, and then it balloons, kind of opens up out there, and that's kind of where it got its name from. Okay, so a brief history of this Takotsubo. So this, again, Dr. Sato first recognized in 1990. That was that paper I showed you. Throughout the 90s, it became more apparent in Japanese medical journals. Still hadn't really come to the States yet. In case reports, in other words, that they describe a case, hey, look what I saw, which would be like our Jane Doe. And in small case series where they get a bunch of cases, they say, hey, these all look kind of similar, okay? And then they put them in papers, medical papers. And then in 1997, Dr. Pavin wrote about 2 cases that they saw of reversible left ventricular dysfunction precipitated by acute emotional stress, which basically is just what we just talked about, okay? So this is the first time in the United States or the Western world that we kind of started talking about it. Again, here's more history. In Japan, they reported about the syndrome to the West. In other words, they let us know about it. So in other words, it wasn't in a Japanese journal in Japanese that none of us could read. In 2001, they're named transient LV apical ballooning. So that's another name we have for it. So now we got a bunch of names for it. Then international audiences in 2005, when the New England Journal of Medicine first talked about it. And then finally, it was recognized by the American Heart Association as a specific problem in 2008. What's the prevalence? So again, we originally saw it in 1990, and prevalence means how often does it happen? Now this accounts for 2 to 3% of heart attacks. I want to make it very clear, this isn't a heart attack, okay? So it's 2 to 3% of people that present looking like they have a heart attack aren't really a heart attack, they're this instead, okay? So the true prevalence, meaning how often it happens, is uncertain, but what you can see, at least as far as the reports are concerned, this is from 2006, and I believe this is the United States, it's going up. 2006 to 2012, the number of reported cases is going up. Published papers on the subject, so in other words, now we recognize it, and then we start studying it, and that's where papers come from. Again, you see, starts out not much, and all of a sudden now it's jumped up, because now it's something that's recognized. And so now we got to figure out, well, where's this coming from? You can Google it and find out information about it on Google and even on Wikipedia. All right? So this is something that now has reached, the general population, and now other people can look into it and talk about it. So what, in general, are the characteristics of folks who have Takotsubo? And I'm going to call it Takotsubo, not broken heart anymore, because that's the name I know it by. Women are about 9 times more likely to develop it than men. And we'll talk a little bit about that in a minute. Women more than 55 years old have about 5 times the odds of getting it than women under 55. And we'll talk about that in a minute. The peak incidence in the summer, and I don't know where that comes from. Maybe there's more stress in the summer, I don't know. It seems like you're on vacation, so that'd be less stress, but. Recurrence is not uncommon, okay? So about 10% of the time when you have a case, it's because it's somebody who's already had a case before. So it can recur. The history is about 40% of the time there's acute emotional distress, stress of some kind, death of a loved one they talked about. In this case, it was the dog. Confrontation in an argument, acute anxiety. About 20% of the time it's a physical stress, like a medical problem, they had an asthma attack, they had a surgery of some kind, drug withdrawal or alcohol withdrawal. And then about 30% are not known. So, but a lot of them are associated again with stress, either emotional or physical stress. Now, what's also been looked at is the type of stress that causes this seems to vary between men and women. So I mentioned that mostly it's women, but there are men that get it as well. And so in women, it's mostly emotional stress, about 95% of the time. And in men, about 80% of the time, it's physical stress related. This is just talking about, again, the Aspirus experience. In 2010, there were 64 cases that were identified as fitting the description of Takotsubo. 62 of the 64 were female. Emotional stressful situation was present in 42 of the 62. Of the 2 males, one had been castrated as part of treatment for prostate cancer. That's pretty traumatic. The other was found to have an adrenal tumor that secretes adrenaline, and we'll talk about adrenaline here in a little bit. And then had a second episode a couple of weeks later, after the first episode, and we'll talk about adrenaline, because that's going to be a key player in what we're talking about. And now at Aspirus Wausau, they're talking about seeing about 1 case a week of this. Prognosis in general is good. Our Lady Jane Doe, she was out of the hospital in 2 days. Heart was back to normal. Okay? So outcomes in general are good as long as people don't have other comorbidities. That means other medical problems. You know, if your kidneys don't work, your lungs don't work, et cetera, and then your heart doesn't work, then that could be a bad thing. If on the other hand, you're generally healthy, and she was apparently generally healthy, taking her dog for a walk out in the woods, generally the outcome is good. Heart function normalizes usually within days to weeks. It's rare to have somebody die in the hospital, although there is, I just read a paper recently that says that maybe that's under-recognized, and that actually the in-hospital problem may be a bigger thing than we think. And again, about 10% prone to recurrence. So some obvious questions. What's the cause? And we'll kind of talk about that a little bit. Why women? We'll talk a little bit about that. And then other things. So possible mechanisms that have been trying to, so again, this has been trying to figure out, well, why does this happen? Because especially those of us that are doctors, we want to know, why is this happening? Because until you know why it happens, you can't figure out how you're going to make it not happen. So possible mechanisms, multi-vessel coronary spasm. Remember I showed that heart catheterization with all those, arteries that were coming down? So they can spasm. There's muscle cells that are inside all those arteries to regulate how much flow is going down each artery at any specific time. And just like, you can get a spasm in your calf muscle, you get a spasm in those arteries too, in the muscles in there. And so one of the theories was maybe a bunch of arteries all spasmed at the same time. Microcircular dysfunction. I'll talk about that in a minute. There's another picture. I think the next picture shows a little bit about that. Direct cardiac effects of stress hormones. That's, again, adrenaline that I was talking about before. Okay? And then talk about, again, there's a picture of what the adrenaline molecule looks like. And this is noradrenaline, which is another stress molecule. And what I'll kind of cut to the chase a little bit is we kind of decided we think it has to do with these. This is just a picture of large coronary arteries. As they get smaller and smaller and smaller, you get this microcirculation because it's like the branches of a tree or the roots of a tree where it gradually gets smaller and smaller, and you eventually get down to the very small levels, and that's microcirculation when it talks about this. So let's talk about multi-vessel spasm. Again, it's been reported in some of these cases to have multi-vessel vasospasm. And then when we have tests that we do to try to provoke people to have spasm of their arteries, and a percentage of them, about 25%, a little over a quarter, you can make spasm by giving them this medicine. But 25% ain't 100%. So it doesn't seem to clearly answer the whole question, even if it is part of the question. This is that microcirculation again, and this shows that you got the big arteries here, but then they gradually get smaller and smaller and smaller. So the question is there some dysfunction with the little arteries as they get smaller? And maybe that's the problem. And so this is talking about microvascular disturbance. The There's a vasodilator that basically should make blood vessels plump up and get bigger. It's called adenosine, and patients with Takotsubo generally have a poor response to that. So that kind of supports the idea, well, maybe it's a microvascular problem. But again, it doesn't prove cause and effect, and it still doesn't seem to explain all the cases that we're seeing. So basically, currently, there's undoubtedly some accounts, spasm accounts for some of the Takotsubo. The microvascular accounts for some of it. But it probably isn't adequate to explain all of it. And actually, most of them are probably related to this. So catecholamines, that's just a fancy term for the stress hormones, all right? The fight or flight hormones that everybody hears about. And the one usually we're talking about is adrenaline, okay? Adrenaline comes from the kidneys, or adrenal glands on the kidneys, I'm sorry. And then basically with stress, these glands secrete a bunch of this adrenaline into the bloodstream, which then acts on the body. And then there's also then a noradrenaline, which is what's called a neurotransmitter. It works more at the nerve endings, but it's a nerve endings at the heart that can affect that. And it's also a stimulant. And so what that does is it generally increases heart rate, increases how hard the heart pumps, and increases blood pressure. All right. So that's part of that fight or flight thing. If the saber-toothed tiger and you're a caveman is trying to get you, you either have to fight off the saber-toothed tiger or you have to run away from the saber-toothed tiger. Okay? So that's what this is supposed to try to help you do. That's what these stress hormones are all about. Okay, this is looking at there's beta receptors. Again, I talked about they increase the heart rate, they increase the contractility. That's how hard the heart squeezes. And it has to do with calcium, okay? And calcium moving from place to place that causes that to happen. And that's going to be important a little bit in a second. Talks about there are proteins that have to do with this calcium. So some observations that suggest that catecholamines, again, that's the stress hormones, may be causing this problem. In people with Takotsubo, circulating levels of this norepinephrine, that's the nerve transmitter, and epinephrine, which is also called adrenaline, those are other names for it, are 3 to 5 times higher than those found in patients that are having a typical heart attack. So these hormones are circulating at a high level. Numerous case reports of administered catecholamines cause Takotsubo. So in other words, sometimes we give people these stress hormones for different reasons, most commonly in the operating room or in the intensive care unit. And if you give a high dose of them, there's reported cases of that causing Takotsubo on people. So this is an example of that. So this is another case, again, not my case. Mary Smith, 44-year-old female, undergoing outpatient arthroscopic shoulder surgery. So orthopedic surgery at a standalone orthopedic center that does surgery. Normally, epinephrine is placed in the surgery irrigation line. So in other words, it's not part of what goes to the patient. It's used for other things. But inadvertently, it was put in the IV line instead. Yeah, can you say lawsuit? This gave the patient a large dose of this epinephrine, also called adrenaline. Okay, so she got a bolus, a big bunch of this adrenaline. She became acutely ill with chest pain, was taken by ambulance, because again, she's at a standalone place, to the Aspirus Wausau emergency room. Her ECGs suggested a heart attack. Her exam showed she was in heart failure. She was taken urgently to the cath lab. Her coronary arteries were normal. Does this sound familiar? It sounds just like the lady that had the dog, all right? She was in shock. I won't tell you what an IVP is, but that is a way to try to maintain blood pressure. Put on IV beta blockers again. I talked about beta blockers on Mary Smith. So again, beta blockers used, she rapidly improved. She was sent home in 3 days with a normal heart function again. Summary of Mary Smith's case. Middle-aged female, developed Takotsubo syndrome after inadvertently given a large dose of this epinephrine or adrenaline. The same hormone that adrenal gland releases under stressful situations. No coronary blockages were noted again. And she had rapid and complete recovery. This is an article written by my good friend Dr. Murdoch that I was said to put these slides together, where and that's his son actually. This David Murdoch is the dad. That's his son. Who I think is in Colorado, it's no Portland. Where they describe this. What's called. Well, actually, I'll get to it in a minute, but basically of getting the drugs and then that causing Takotsubo. So this is an article that was written by Dr. Murdoch up in Wausau that has to do with the drug-induced Takotsubo. And that's the it's pharmacologically induced Takotsubo syndrome, or PITS. And this is the characteristics of people that get that, and basically there's 101 of them, 89% of them are female. Now that either means they're getting lousy care and getting injected with things they shouldn't get injected with, or they're the ones that are responding to it. They're a little bit younger than the folks that get Takotsubo, but still in the same general age range. Again, dosing errors, heart catheterization was performed in 84% of them. They're looking for the blockages. The ejection fraction, normal is 50 to 60%. These people are 32% on the average. And had congestive heart failure, whatever. And then they talked about the apical ballooning and other things. Presented like they were a heart attack, and then 99% survived, and 100% of the survivors had normal heart function at the end. These are some of the agents that cause PITS, pharmacologically induced Takotsubo syndrome. And the thing to notice is most of them fit into the stress hormone or stress hormone-like category, okay? So that's where that suggests that the stress hormones are involved. So why would this happen? How could high levels of adrenaline and high sympathetic nervous system activation cause this Takotsubo? And the theory is, or at least the current theory is, because these things always change, is that this is related to something called a G protein that is on heart muscle cells, and it has to do with this beta-2 receptor, and the beta-2 receptor affects the G protein, and the G protein usually stimulates the heart and makes it squeeze harder, which is why you get increased contractility, increased heart rate, usually with these stress hormones. However, what this study showed is that when there's a big dump of these adrenaline type hormones, these G proteins can flip to becoming, instead of being activation proteins, they're depression proteins, and they actually depress function. And so that's kind of what this is talking about here. You get a beta-2 receptor switch to inhibition from stimulation. And so what ends up happening is you don't get the calcium flow that you normally get. Which then creates this situation. So most of these beta-2 receptors that cause this problem are at the tip of the heart, okay? The apex, and that's where this apical ballooning comes from, because suddenly these squeeze fine, and maybe even because of the adrenaline, may be hyperactive, because again, it makes it really beat down and contract hard, and these then suddenly don't contract. Well then, because these are pushing down and these are not, it makes it balloon. It kind of like blowing air in a balloon, because it squeezes and pushes it all that way, and then it balloons out, okay? So this is basically the current theory. Now this is another picture of the same kind of thing, so I don't think we need to go through that, but the bottom line is that appears to be what we currently think is the reason for it. So again, it's these stress hormones, well, fight or flight, adrenaline, etc. Why does age? How does age play into this? There's not a lot of research in it, but we do know that estrogen and the nervous system are likely involved, because we talked about it being postmenopausal females. Because once women go through menopause, the estrogen levels drop, and so estrogen probably is protective in some way. Also, the sympathetic nerve activity does increase with age. And that also, which also explains why there's blood pressure increases as women get older. Again, estrogens tend to go down. I don't want to talk too much about the hippocampus because I can't pronounce it very well. But the bottom line is that you have these stress things that kind of change when you go through menopause. And again, this is just another picture showing kind of the whole thing. You've got brain to nerves that affect, well, first of all, here it's to nerves that directly affect the heart, and here it's to the adrenal gland, which then dumps these epinephrine, adrenaline hormones in, which then have a negative effect on the tip of the heart. And this is kind of trying to put that whole thing together. So why do some women get Takotsubo and others don't? There seems to be, again, a difference in the nervous systems of women who get it compared to those who don't. And they have a more heightened stress response. In other words, their heart just responds to these things more so than others. Why women more than men? Some women may get a more heightened sympathetic response to stress than men. Again, sympathetic being the adrenaline thing. Testosterone may be somewhat protective. Women's heart may be more susceptible to Takotsubo than men's. So again, the question is the female heart different, female nervous system different, or maybe both? And I'll be honest with you again, what did I say? I said that kind of around 1990 is when we kind of started learning about this, and then you saw, starting in 2000 to 2010, you saw all the articles start to increase, but this is a fairly new thing for us. So there's a lot of gaps in the knowledge because it's something we are just learning about. So again, here's some evidence of increased susceptibility of the female heart itself. Dr. Murdoch, again, I keep bringing him up. About 90% of the PITs, that's that pharmacologically induced, occurred in women. Again, they weren't the only ones getting mistakes made and getting that stuff injected, but they were the ones that were having the responses. So women's heart may intrinsically be more susceptible than men's. Women's sympathetic nervous systems are more active. Testosterone and estrogen seem to protect, and women, as estrogen seems to goes down after menopause, and so that is likely, at least that's the current theory about why this might be happening. Conclusion: Takotsubo syndrome is dramatically increased in frequency since it was first recognized in the 1990s. It has a strong female predominance. Its post-menopausal females are most susceptible. The prognosis is good. But again, recurrence is not unusual. Somebody said they had it twice. That's not unusual. It's not the most common, but it's certainly not unusual to see that. Most cases are due to direct effects of high nervous system tone and have somebody who has a susceptible heart. Treatment includes beta blockers, which help. And I didn't really mention this, but I talked about that beta-2 receptor and how that adrenaline stimulates it. Beta blockers, that's what it is. Beta blockers. It blocks the activity of adrenaline. Okay. And that's why we think that may be helpful. And then there's several commonly used drugs that may cause or facilitate Takotsubo, like we talked about the adrenaline that we use sometimes in the operating room as our example. Why are we seeing so much more? I mean, that's one of the questions, right? Perhaps we're simply more aware of it, and it's been there all the time. That's something we see in medicine a lot. There's a lot of things that kind of we didn't really know was there, and then when we see it's there, all of a sudden, everybody's got it. It's all over the place. That's not an uncommon thing in medicine. Perhaps we're doing something we didn't do in the past. Calcium supplements, things like that. There's thought that because I talked about calcium is involved in some of this. So maybe that's what it is. Perhaps there's something that we've been doing that makes women more susceptible. There's what we talk about estrogens and stuff like that. So is this something that's involved? We don't know. Or just perhaps the world is just more stressful than it used to be. Every generation thinks that, right? So that's Takotsubo basically. So again, it's called broken heart, and it kind of fits because again, a lot of especially the early stuff is related to emotional stress. And again, losing a loved one was a common thing. You wouldn't some of the cases, and this is stuff I just heard about that aren't like my cases, and certainly aren't these cases, but are like people who lose a spouse and then show up. They get chest pain and then they end up looking like they have a heart attack and they get evaluated and they don't have a heart attack and then eventually they get better, that's a fairly common presentation. So, again, it is becoming more common, it's becoming more recognized, more research is going into it, we're learning a little bit how to deal with it. Good news, prognosis is generally good. Bad news, you may get it again.